My name is Sanjeev Arora. I'm a gastroenterologist by profession, and I serve as the director of the Echo Institute. I'm asked to talk a little bit about Echo and share some thoughts about it, about what it is. And I thought the most helpful thing would be to share with you how Echo actually started. So the year was 2001. I'm a professor at the university here, and I went to see a patient in my clinic. And in the room was a 43-year-old woman. And I asked her, how can I help you? And she said, I have hepatitis C and I want treatment. So I said, how long have you had it? And she said, I've had it for 8 years. I said, why did you not come earlier for treatment if you had hepatitis C for 8 years? We've had treatment since then. And she said, I'd called your clinic and there was an 8-month wait to see you. And your nurse said I would have to drive hundreds of miles to see you. And I would have to make 12 trips because there were no specialists in the town that I live in. And there was no way I'm a single mother, I have 2 children. There was no way I could make all these trips to get treatment. So I decided not to get treatment. So I asked her, why did you come today? And she said, I'm having pain here in the right upper side of my abdomen. I did an ultrasound of the abdomen and found that she had a cancer of her liver, which was slightly smaller than a tennis ball. And it was now too late to have a curative operation or liver transplant. And she passed away 6 months later, leaving these 2 children. So I asked myself, why did she have to die when there was treatment and the medicines were available, and she lived in the United States, in New Mexico, rural New Mexico? And the answer was she died because the right knowledge didn't exist at the right place at the right time. That is why Echo started. There were 28,000 patients in New Mexico who had hepatitis C, but less than 5% of them had been treated. And we anticipated 8,000 people would die if you don't get treatment to them. So I developed Echo based on the idea of democratizing expert knowledge. I asked myself the question, what if I could multiply my expertise 25 times? What would happen then? And so the model was based on the idea of using technology to leverage expertise, sharing best practices. So I went around and set up 21 new centers for treatment of hepatitis C in New Mexico, in primary care sites. And I gave them my protocol, but not a single one of them was willing to treat patients because they said this is chemotherapy and it's too dangerous. So I asked myself, how did you become an expert? And when I did my fellowship in Boston and Massachusetts, I would see a patient present to my professor, see another one present to my professor. And after 2 years, they started calling me a gastroenterologist. So I said, aha, I'm going to use this model to create new hepatitis C specialists. I was going to multiply myself more than 20 times so that everybody in New Mexico could get treatment. We call this third principle of Echo case-based learning, iterative guided practice. The same way you teach your daughter to drive a car, you do again and again practice with her. And so I started in 2003, the first Echo clinic, where all 21 would join, share cases with each other. And I found a year later, they became experts. The wait in my clinic fell from 8 months to 2 weeks. And we published in the New England Journal of Medicine that they could produce the same level of care as we could at the university. This was a game changer because 6 billion people in the world don't have access to the right knowledge at the right place at the right time. And democratizing knowledge is the first step to develop a sharing economy and produce more equity in the world. We know that 1,800 children die every single day of diarrheal diseases, and only if the right knowledge was there, their lives could be saved. And knowledge has a different physics than money. Is that when you share it, it grows, and that's the heart of Echo. So we started using Echo for diabetes and HIV and rheumatology and chronic pain and mental health and addictions, which now mental health and addictions have become the largest use of Echo around the world. And lastly, we started training other academic medical centers in the world to do Echo and give them our software and Zoom platform and many, many other technical assistance and training. And we did this all for free. Currently, we have more than 605 hubs in the world. These are academic medical centers, usually operating out of 51 countries. In 2020 alone, there were 1.3 million learners in Echo in 179 countries. And they are making a difference in the lives with 70 different disease areas. And in every part of the continent, for example, Africa, they'll be more focused on TB and HIV. And in Europe, they may be more focused on diabetes and geriatrics and so on and so forth. But those are just the few things I wanted to share with you.
So I'm Sharon Beatty. I have the honor of being the track leader for Radically Rural. It's our first year for a healthcare track. There are several other tracks. You can see all the stuff on the web. We appreciate you hanging in there with us for a little bit. We do have an exciting program. Sanjeev is absolutely an inspirational man. He has done so much for healthcare for rural areas. I've been in healthcare for more years than I want to admit. And I've always been an advocate for rural and worked in a rural environment. So I'm going to introduce the leader of our program today, who's Dr. Jeanne Ryer. She's the director for the Citizens Health Initiative in New Hampshire. She has done yeoman's work for years in promoting healthcare in rural as well as what we call urban environments. There really are no urban environments in New Hampshire, just so you know. And I'm going to let her introduce the crew that's with her today, and we're just passing the laptop around until things get better.
I know Sanjeev has gotten off, but I am so grateful to him for joining us. Every time I hear his story about founding Project Echo, I get chills and I get a tear in my eye. It is clearly, I've been around in the field for a while, and it is clearly one of the biggest, most game-changing ideas that I have ever seen in my career. So we're grateful to Sanjeev for joining us today. We're also grateful to have Project Echo as a tool. But today we're going to talk about a little bit broader than just Project Echo. We're going to talk about how telehealth can improve and sustain the healthcare systems in rural communities. So can you guys get my slides up, do you think? And we'll go from there. Our order of the day is that I'm going to talk for about 5 minutes or less, and then we're going to have a couple of conversations with some of our partners here in New Hampshire and in Colorado. Okay, so the first thing we're going to talk about is what's telehealth. So you've probably heard about telemedicine and telehealth, but let's get the definition of telehealth down first. It's the use of electronic information and telecommunications and patient and professional and health-related education and public health and health administration. So that's what we're talking about broadly. When we talk about telemedicine, we would tend to be talking about, a clinical encounter over a telecommunications modality, which could mean like something like a plain old telephone or something like we're doing right now. So we've got people on either on Socio or in the room who've experienced many of these things, and we're really looking forward to having them share with you. So forgive me for the juggle, but why should you care about telehealth and about healthcare in rural communities? Well, let me tell you this. Healthcare is a driving factor in rural communities' economy. If you look at your local rural community, you should assume that the local healthcare provider or hospital are a major provider of jobs in your community. Add the nursing homes, add the outpatient centers, and you are talking about a lot of jobs in your community. And if you don't think this is the case, think about what happens in communities where the rural hospital closes. And then all of a sudden, anywhere from hundreds to even thousands of jobs are lost or displaced. Rural healthcare is essential for economic vitality. So employers or companies are not going to locate to your community if you don't have a viable healthcare system. And they're just not going to come. And it is also key to attracting and retraining residents of all ages. In my community, we have elders leave the community when they get to a certain point in their lives because they can no longer sustain having to drive 60 minutes to get their health care. We also have people who won't settle in our community as young people because it's too far to get maternity care and to deliver a baby. So we're going to get into that in a little bit. And then, of course, a viable and vibrant healthcare system is essential for public health. And if we have not learned anything in the last 18 months, we should have learned a big lesson about how public health is essential for our communities. So rural healthcare is at risk. And in the room here, I don't know if you can see them, but my colleagues who've been working in New Hampshire and elsewhere in the country to try and support rural healthcare are going to really understand this. The slide's a little small here, but 21% of rural hospitals are at risk of closing because of financial pressures. And I think now if we add the workforce pressures and the inability to get workforce, that number is probably higher. If you look at that map, you'll see that in some states like Alabama, for example, half of their hospitals, their rural hospitals, are in danger of closing. And since this slide was put up, we probably have lost some along the way. What we haven't done a good job of in this country is to figure out what array of healthcare needs to be provided in a rural community. So we really need to, it's possible that we can't sustain a hospital everywhere in every rural community, but we need to figure out what are the essential services that need to be provided locally and how to provide them and how to make them economically sustainable. So the other impact of that, and this is particularly a challenge in our state right now, but I know it is across the country, that rural maternity wards are closing at a pretty alarming clip. And in the middle of New Hampshire, we now have a huge swath of New Hampshire where all of the hospital maternity wards have closed over the last 5 to 10 years. So you have to drive further and further to get prenatal care. You have to definitely drive further when you need to have a baby, because that is one thing that you cannot do by telehealth. There's a lot that telehealth is good for, but actually delivering a baby requires an in-person experience, right? Somebody's got to be in the room. So these are all concerns that we need to think about as rural communities, and our friends in rural economic development, arts, culture, environment, all need to work together to make our communities' healthcare system thrive. Everything changed for telehealth when COVID began. And you don't need to climb into the details of this graph, but you can just see that beginning in March of 2020, telehealth visits skyrocketed. They just went up like this, and everybody had to pivot. I think I'm going to ask Deb Cross to talk about this when she has our conversation. Everybody turned on a dime to start providing telehealth and had to figure it out along the way. And then we had to figure out how they were going to get paid. The patients actually, I think, did pretty well at adapting, I would say, and the providers did a really great job as well. You can see here in this little graph, there's, the same things happen by age group, by poverty level, and in rural and urban areas. What this graph probably looks like now, though, is that that's probably dropped back down. And we've had a return to mostly in-person visits. It's higher than it was before we began. But I'll be a little provocative and say that's not because the patients don't want to continue to get telehealth. Sometimes they want to be seen in person. Sometimes they'd really rather not drive an hour for a 5-minute visit to get their test results. They'd like to have a telehealth visit for that. Thank you very much. But really, it's been, in my opinion, being driven by provider needs, and we need to understand that providers have had a rough couple of years here, and we need to take care of them, but also, frankly, by how things get paid for. So that's a concern going forward. And so what can telehealth do for your community? It'll help you retain your current healthcare providers by giving them education and collegial support. I think we're going to hear that from our friends who are have been participating both in ECHO and also doing telehealth. It'll help you attract new providers. People want to come where they're the kinds of supports that will help them stay in their community, where they'll be able to get ongoing education. It'll help you attract and retain community members of all ages. And as Sanjeev said, it can increase access to specialists for your residents in your rural community. It can decrease healthcare travel time and expense for your residents, and that is by a lot if you have to travel hours to a specialist. We're a little spoiled here that Boston is so close and Worcester is so close, but they're still a few hours away. And if you could see somebody in your living room, let me tell you, you probably, if you're sick enough, would really rather not be making that drive. And it does increase safety and comfort. As someone who has had ill and elderly family members, driving 2 hours over the frost heave in New Hampshire to see a specialist is not really a very fun thing to do. So there is change and there's challenges. Payment for telehealth is improving, but it's still in flux. I'm happy to say that Medicare is really advancing its rules and also trying to understand that rural communities often don't have broadband and not everybody has great internet at home. And so they're allowing for use of plain old telephone service to provide certain kinds of visits. And that's not final yet, but I'm optimistic about that. We need to support telehealth education for all kinds of professionals. We need to develop strong, trusting partnerships. I think there are challenges. Telehealth can be great in a rural community if your health system is connected with a larger one, and you can have a seamless network with a larger health system. What can happen, though, and we need to worry about this a little bit, is external disruptions, where all of a sudden you have a primary care provider in town, you really need to keep that primary care provider in town, and then all of a sudden there are remote telehealth options from somewhere else who are seeing patients in your community, and now they're not coming to you and you don't have any revenue to keep going. So that is a concern. And we also need to find ways to keep an eye on quality, because as we know, I'm kind of pretty passionate about healthcare quality. And as we know, the quality is not always even, and we need to maintain and assure that the person that you might be seeing on the Teledoc site, whatever that is, I didn't mean to use a brand name, is as of high quality as people who might be licensed and credentialed in your own community. So at that, we've heard from Sanjeev. We're next going to hear from Lisa Bean and Robin Nelson, and then talking about Project ECHO and their experience. And then we'll have Deb Cross and Julia Johnston join and are also here to talk about what it's like to do rural telepractice. Okay, great. So the question and this is, unfortunately, this can't be a short answer. So the question is, if rural hospitals are in danger of closing, why are there regulatory impediments to their joining with larger healthcare systems? That is a big question. I would love to talk with you about that. We would need at least an hour and a half and then about 6 weeks. So there are certainly lots of discussions here in New Hampshire and elsewhere about healthcare acquisitions and mergers and what the implications are for local rural communities. I think we should do an issue brief on that. And I'm going to go back to the office and see what we got. All right. I will follow up with you. Make sure I get your information.
But on a happy note, the feds did relax some requirements so that telehealth visits could actually get done and billed through Medicare and whatnot. So that was helpful. At least that was a start. Okay, moving on back to Lisa Bean.
Okay. So I've got some questions for Lisa Bean and Robin Nelson, and I want to introduce them quickly. So I'm going to have actually Lisa introduce herself and then Robin, but because we're going to have to play past the mic. But both Lisa and Robin are nurses and nurse administrators in long-term care facilities, nursing homes, and they've been participating with us for more than a year in a Project Echo session on COVID and nursing homes. So what, because of our little choreography that we need to do here, I don't know if we can get Robin up on the screen as well. That would be great if you can do that. But first I'm going to ask Lisa. Oh, there she is.
Yes, yes.
And Robin is literally up the road, but because of COVID and other things, she can't join us here in person. So I'm really glad to see you, Robin. So I'm going to ask Lisa a question first, and then and then I'll ask Robin something similar. So we may have to play past the mic here. So Lisa, tell us a little bit about your work in this rural community and about work in a long-term care facility at a nursing home. Okay. Should I give her this mic?
So is the laptop mic still on, or do we need to pass
that mic?
Pass this mic. Okay. Hi. Can you hear me? Okay. My name's Lisa, and I work here in Keene. I've been in long-term care for 30 years in 2 different facilities and a variety of roles. Right now, I'm an MDS nurse, clinical reimbursement coordinator, and I've played a variety of roles. I've been a director of nurses. I've been an assistant director of nurses, and I've been an educator in LNA programs. So I've had a lot of experience with entry-level staff and maintaining the staffing. And then I have a big interest in infection control, which was what drew me to the ECHO project.
Oh, okay, now.
Sure. So thank you for having me. It's a pleasure to be here, or here and there at the same time. So Maplewood Nursing Home is a county-owned and run facility. We have 150 beds. Right now, we only populate 99 of our beds due to staffing shortages. My roles at Maplewood have gone from LNA to occupational therapy aide to MDS nurse like Lisa, assistant director of nursing, and now I'm the director of nursing services. Our building is probably about a half hour, 20, 25 minutes, half hour out of Keene, depending on which route you take. We're very, very much in the woods out here. We have a farm to our south, 2 farms to our north, east, and the Connecticut River to the west of us. So we're pretty isolated out here, but when we started our building renovation and expansion project, all of the residents were asked, would you rather stay in Westmoreland or would you rather go to Keene and build in Keene? And they all wanted to stay here because the landscape is so beautiful.
Both answered the same question next.
It was really in facility focus. There were not any of the group meetings that we were having with sister facilities. They were, put on hold. Obviously, the travel also kind of self-containing in the buildings. And we were needed in the buildings. You couldn't afford to have people off at seminars and off at educational things. So everybody had to do all kinds of jobs within the facility. So you had to be local and you had to be there. I think that's what changed. I think also the changing regulations and rollouts and changes of procedures were constant. And I think that too made it very important to be at the facility. And how do you interpret that for your facility?
So Robin, can you take on the same question?
As Lisa mentioned, everything changed. There's not one thing that we do the same that we did prior to COVID. Some of our networking meetings, like the National NADANA Director of Nurses group that we have in New Hampshire, we weren't able to meet anymore. So then we changed to Zoom meetings. So that was huge for a lot of people, changing to more electronic meetings rather than in-person meetings. Again, like Lisa said, we couldn't afford to be out of the building, so we couldn't have our quarterly meetings with the local hospital where we would coordinate care and make sure that the administration at the hospital was working together well with the nursing homes in the area. Everything kind of just came to a dead halt, and then we were invited to the ECHO program, and it seemed like a good solution to answer our questions and help us decipher the regulations. So yeah, everything changed.
Watched you. We had an online relationship with Lisa and Robin and 100 and something other people.
Right.
But I watched you. You were like really busy. And how did you make time for those weekly ECHO sessions? And why did you do it? And what did you get out of it?
Okay, for me, why did I do it? Well, I had that interest in infection control, and it was about COVID, which was so new to us. I also felt like in my position, our building changed ownership right in the middle of the pandemic. So we had been part of a large corporation where we were getting a lot of information. We had a lot of resources. We had people we could reach out to. We had other sister facilities that were constantly, able to connect with, and that changed. I'm not saying that some of the people we knew we wouldn't be able to talk to, but the relationship was different. And it was a new ownership and out of the area ownership too. So that became a reason for why don't I connect? And I was interested in infection control. So I thought that was a perfect opportunity to have the same people over and over to talk to and commiserate with and offer ideas or challenges. I think early on, Jeanne, I offered my scenario of a difficult situation that I presented, which was part of what ECHO asked us to do, is to bring questions to the forefront. So I felt really good about that they were interested in hearing what my particular issue might be, how I solved it, and give me more ideas. And the other thing, I felt like it was a way for me to feel like I was in that learning environment still, that I was with others who had the interest of learning and getting better and improving ourselves. So that's kind of why I joined. Why did I make time? It became one of those little kind of times in the day or times in the week that I looked forward to, that I could separate from the minute to minute, day to day, what was going on in the building, and say, oh, I need to go to this, and I'm going to sit there and I'm going to give it my all. And I'm going to let go of the five or six things that I had been given first thing when I walked in the door. So it became almost a refuge in a way, and a place that I felt was about me. And I hoped I could take information from that and bring it back to my practice in the building. I initially had I had an LNA that did it with me, and she really enjoyed it because she isn't necessarily part of those kinds of meetings before. So it was interesting to hear her take on it and be interested in it as well.
Great, thank you. And Robin, can we ask you kind of the same question? Your team was really committed. You often had more than one person there. And why did you do it? What did you get out of it? How did you make time?
So I think probably the best value that I got out of it initially was validation. Just to hear that there was so many people there who were going through the same things that we were, feeling the same feelings about what we were going through, experiencing the same frustrations. It was very therapeutic for us to be able to sit in a forum where everybody was going through the same thing. We were not only in the same storm, but we were all in the same boat as well. So that, I think, was really valuable. The other thing was we got to, like Lisa, we were very involved with sharing some of our challenges, questions, and just to hear how other people were approaching things. It was like a big brainstorming event. And it gave us a chance to put a problem out on the table and have a group help us solve a problem. But it also helped us feel useful because other people would put a problem out on the table and we're like, hey, this is how we're approaching this. Why don't you try it this way? You can build off of that. And so that was very important to us through the ECHO group. It helped us feel like we were doing something, anything, because we really felt wrapped up in, okay, what's the regulation today? What's the HON say? What does CMS say? What's the new governor's emergency order say? And then one of my favorite parts of the whole thing was near the end, we did a quality improvement piece with Trisha Zahn. And I still to this day am handing out the phrase like candy, give yourself grace. And I have to remind myself that on a daily basis, that we're all going through this together. Nobody's perfect. Mistakes are going to be made. Miscommunications are going to happen, and just give yourself grace.
So here's a question for both of you. Again, we're going to go to Lisa first. You've talked about the staffing shortages, nursing shortages, all kinds of workforce shortages. How do you think Project ECHO and other forms of telehealth, so not just ECHO, but other ways you could use telehealth in your facilities, can help with the nursing and other staffing workforce shortages in long-term care, in rural long-term care?
Well, I think our experience early on was to try to tap into some non-clinical people. The administrator at the facility early on started looking outside of where we usually get people, LNA source or something like that, was somebody that could do some of the roles that are not so clinical and free up those people that really needed to be involved in the clinical. So opening it up for the screeners at the front door that became so important. Did that really need to be a healthcare professional? Not really. They needed to be trained. They needed to have some guidelines and such. Bodies have more faces there on the units with them. And I think we experienced it. Some of those people went on to the LNA course. They got their toes wet. They came into the system and saw it maybe different than what they might have imagined, or maybe never having imagined it at all. And they kind of became committed to the process, the residents, what we were doing. And they also felt more in tune with how this was really affecting people in long-term care, whether it was the residents and the staff. So I think the outreach to the general population saying, there are things you can do here. You don't have to be a nurse. You don't have to be an LNA only. And having us be more transparent, unless you have a resident there, you might not be coming in. Unless you work there, you might not be coming in. But this opened it up for more people to come in and participate. And a lot of the community wanted to know, how can we help? So this was ways to bring in some people that way. And I think telehealth for the staff made it easier to communicate with the professionals, to set up appointments so they weren't missed. And also it freed up, because a lot of times with our population, we have to take a staff member to go with the residents. So now you have one-on-one, and you've taken that staff member away from a working partner on the unit, which can be difficult. And then we had the transportation issue for some of the residents too, like you had said, Jeanne, very difficult to feel comfortable and feel safe and going out in the community. So I think that's how it can help.
Great, thanks. So that same question back to you, Robin. How do you think ECHO and other forms of telehealth can help with that nursing and workforce shortage?
So yeah, telehealth in general was really a godsend. We have, because we're so far out, we have transportation aides who are LNAs who do the transports to appointments. Of course, initially, we weren't sending anybody out. We were too fearful of exposure, risk of infection. So we pulled back, and only the emergent cases were going out. Our transportation aides picked up the telehealth just like that. They were able to pivot. We got the resources we need to get the correct kind of equipment to have a proper telehealth meeting. So by using telehealth, we reduce the risk of infection. Some residents do not like to go out. They would just be happy to stay right in the building, even on a non-COVID day. So they were very thankful for that. As Lisa mentioned, very helpful for us as the nurses to be able to talk directly to the provider rather than sending a note with the resident to an appointment and the doctor or nurse sending a note back. Having that conversation is so valuable. And that gives the nurses more time to spend with the residents because they're not calling the doctor back, asking for clarification on orders or clarification on what the diagnosis is. Echo, I think, is a brilliant idea for idea sharing, for staffing shortages, to get workforce groups started. We do have a Monadnock workforce group going on right now. If we can get a group of community leaders together to hone in on some interventions in the community and some resources in the community to get people involved and excited about healthcare, then if we use an ECHO type program for that, we can get more and more people to come on board. And it just doesn't have to be current healthcare professionals. You could get your Chamber of Commerce on board. You could get your local temp agencies, DHHS, and the welfare programs trying to get people back into the workforce, unemployment, all of those. You can get a group of diverse people together to talk about how to get people back into the healthcare profession. Because right now they're leaving much quicker than they are coming in. So I think ECHO would be a great way for people to share approaches, get together and network, and figure out how to at least start a grassroots effort to fix this problem in healthcare.
And one last question for both of you, and it's the same question. As you think about Radically Rural's a national conference, there are people watching from all kinds of places elsewhere in the country. As you think about other nursing homes in rural areas around the country, what advice would you give them about staying connected professionally and building learning communities within your building and across, as you just said so eloquently, Robin, across a whole community and helping the whole community engage? So first to Lisa. And Lisa, I'm going to have you pass it to Robin so we don't have to do this back and forth.
Okay. Will do. I think it's like Robin had said, she uses that phrase about grace. And I think another one we came away with is being vulnerable and daring. And I think try it. Maybe you won't fit in the first one. Maybe you like a different topic, but be willing. Step up, try it, join, listen. Be there just to listen. Sometimes it's not your place yet to be active and participating, but you can get a lot from just listening. You have access to so many people that you wouldn't have access to. The presenters were wonderful. Be willing to speak up with your challenges because you're probably not the only one. And to just be able to state that allows somebody else to feel a little relief, perhaps to feel a little bit more committed and a little bit more able to participate. Also be willing, like Robin had said, about solutions. Your little solution might not have been thought of yet. And why should we have to wait individually to come up with those solutions? If somebody gives it to us and we can use it, it's as good as if you came up with it yourself. So I think being willing to put a little solution or an idea out there that somebody can take and run with it, make it work for their setting, is another reason to commit and to be part of it. You feel connected, like Robin said. You feel like you have a variety of people, all this group of people that are going through the same thing, that maybe have solved some things. Maybe they're further along in their journey than you are. Maybe for us, our building had no positive cases until March of this year. So what I was listening to was what's going to happen when it does. And, by that March, I felt better about it than maybe I would have, having not participated in ECHO. And I was able to take some things from that for myself, for the building, and feel like it had come from a trusted source, feel like some of those things might work for us, because I'd heard it from people that were in the same place, that had the same commitment, that felt as connected to the topic as I did. And be willing to pose some questions, because that's how we all learn. It was like often said in ECHO, all teach, all learn. So it's not teachers and a didactic only, and you listen. You're participating. So you're the teacher sometimes, you're the listener sometimes. And that becomes very fluid, and you don't feel like you're sitting there listening to someone who is giving you all the answers. You feel like it's more of a partnership. And I think that many of us work better when we're elbow to elbow and partners, rather than feeling like we just have to kind of follow the lead and do what we're told. And I think that's a much better situation to live in, to work in. I think people in the industry, in the long-term care industry, would feel more connected and part of the building if they felt that was the atmosphere and the environment too. And Robin, I think it's your turn now.
Thank you, Lisa. So yeah, I would say be the pioneer. Don't wait for somebody else to start. Start it up. Start small. Start with a small hub of people and expand outward. Use your local hospitals, your other local nursing homes. Make it more of a partnership. For a long time, at least in our community, it's been our nursing home versus that nursing home. Well, that staff member came from me to you, and now you're taking one from me and going over to you. And, let's make it more of a community-based effort. So yeah, be the pioneer. Don't wait for somebody else. If you're waiting for somebody else, you've waited too long. And avoid the initial that won't work for us response. That happens so often when somebody brings up an idea that, no, it may not be perfectly suited for whatever your situation is or your how your facility runs. But take that and then build on it. So yeah, maybe that in one block won't work for you, but chop it up into little pieces and take what you can out of each session. So yeah, learn from others, build on that, make a good foundation to start with, and don't be afraid. You have nothing to lose, only stuff to learn and stuff to share.
We're going to try to get you to talk about using telehealth to provide care to, in, and from rural communities. So Deb is a nurse practitioner in a small town near me. It's a ski town. And Julia's out in Telluride, another ski town. So Deb, tell us a little bit about your work as a primary care nurse practitioner and your work in behavioral health as well, and your health center, and about your community. Sure. That kind of stuff.
Yeah. So I'm a primary care nurse practitioner at White Mountain Community Health Center in Conway, New Hampshire. We're about 10,000 people up there. And our health center, we really focus on serving people who maybe are uninsured, underinsured, or lots of people have insurance, but costs are still really expensive. So we really focus on trying to make healthcare affordable. And, with that, we see everything. And where we are, it's about an hour and a half to the next closest major medical center, which would be Maine Med in Portland. And then because we're in New Hampshire Medicaid will not, you can't go to Maine Med. So then you have a whole nother, then you maybe have to travel, 2 hours down to Manchester. So a lot of barriers to get, specialist care for our people. And so with that, same thing with mental health, behavioral health, we do a medication assistant treatment program. If you're not familiar with that, that's treatment for addiction using medications. And that was something we started about 4 years ago, was, brand new to us. And ECHO was very helpful with us for getting that going. But yeah, so kind of we're doing across the gamut, a lot of complicated care for a lot of very high risk folks.
Thank you. And Julia, so Telluride's a ski town. The mountains may be a little taller there. They just might be, you know, and lately you were getting better snow, but that's okay. But you work in a mental health care agency, and you guys are doing some really interesting things out there. So tell us a little bit about you and your organization and the communities that you serve, which is quite a bit of territory. COVID happened. You had to really pivot to telehealth. Did you learn, and how did it benefit your patients?
Yeah, I mean, when COVID happened, we actually pretty much did completely telehealth except for prenatal visits and, you know, some parking lot visits. So it was a huge change. And it was hard in the beginning. Luckily, we had actually just started about a year prior working on doing telehealth in conjunction with Dartmouth for Hep C treatment. So we had, you know, a background of it and had a little familiarity with it, which helped us kind of transition in. I think one of the biggest things that was hard for us was, you know, trying to do those video visits at first because internet never worked. So finally, I think once we started to realize like we can use this with telephone, and people could text us pictures, and that actually worked very well rather than trying to do these jerky in and out video visits. And I think at first everybody, there was a lot of fear, but after people got comfortable with it, people really liked it. You know, I'd say as a provider, I didn't love it. You know, I really like to see people in person, but it's great for clients, you know, in terms of, you know, not having to drive, you know, and especially in the winter, and, you know, not having, and it was interesting as a provider too, to see the household, you know, and like, oh, there's your ferret, you know, you really got a better sense of, you know, what environment people were in. So yeah. And I think now we've sort of transitioned back. You know, we went where for a while people then got sick of telehealth and were like, when can we come in? And we were like, finally we were seeing people in, and now we're in sort of a balance where a lot of folks are enjoying telehealth, and when it's appropriate, we try to continue that for them. And, you know, but if, you know, we sort of offer people a choice of, you know, well, you know what, if this is where just a med follow-up, we could talk over the phone, or you could come in and we could do it here.
Cool. So you're really, it sounds to me anyway, like you're really committed to your community and you like living in a rural area. But I know that it's hard to retain primary care providers in rural areas. And I know Sharon would feel that pain acutely when she ran a health center. Does telehealth make it more or less likely that you're going to stay in rural primary care? And what would you say to rural community leaders in Conway and North Conway about what they should do about telehealth?
Yeah, I think telehealth can definitely help retain providers because it gives you the ability. First of all, it helps with staffing, because when I have a telehealth visit, I don't need any assistance, you know, so, and everybody's short staffed right now. So you can kind of break your schedule up to, you know, have an in-office telehealth. And then you have that whatever half-hour appointment where you just have that time to talk with your person, which is really nice. And that I think is a big stress for providers and causes trouble with retention, is the burnout of just trying to jump from room to room to room to room, seeing people. So as much as I do like seeing people in person, a telehealth visit is kind of like a little break, you know, because it's really a time you can just focus on, you know, discussion. And then also telehealth is also going to help you retain providers, because it helps. If you're patients, you can do a referral. A lot of times I want someone to see a specialist and they don't want to do the traveling. Well, now we finally have specialty providers are also doing these telehealth visits, which we were advocating for a long time and they wouldn't do, but now all of a sudden they will. So, which is nice, but that helps because, you know, instead of you trying to manage this complex cardiology patients are much more willing when you say, hey, maybe you have to go once, drive to, you know, Dartmouth and do an in-person, but from then you can do some telehealth. The patient's going to be much more likely to do that, and that takes a lot of pressure off as your primary care provider.
Cool. Thank you.
Hi, my name's Julia. I actually was promoted and I'm now a manager at Tri-County. I moved to Telluride, Colorado over 5 years ago, Southern Goa, India. I'm a certified mental health first aid instructor for adults, youth, and teens. And I assisted in the development of Southwest Colorado for mental illness chapter in our region. I also instruct classes as a certified NAMI family facilitator and a support group specialist. So our organization kind of serves, it's dedicated to health equity, and we've been around 2011. We serve over 13,000 people annually. Our services started in 2011 with just 2 community outreach programs serving just 3 counties, and now we actually manage over 28 programs and initiatives supporting a 6-county rural mountain region. And like mentioned before, they're very big, very tall mountain regions. So a lot of our community members are really isolated, not only geographically, but also by the differences in our communities. Telluride Ski and Resort is an internationally known resorts, whereas surrounding towns supporting them struggle in various different social determinants of health, low income, some don't have clinics. So we have a vast variety of people we support. Our programmings range from community outreach and education to direct services, like our online therapy program. The programs were created to sort of ensure care is accessible and affordable and just available to all community members, regardless of their socioeconomic status and where they live geographically. Our area, our region is actually known as the suicide belt. We have some of the highest rates of suicide in the nation. And we understand kind of that health is this integrative whole person approach. So our team identifies and addresses underlying social factors that impact an individual's ability to live sort of as healthy as possible. So some of the programs we do range from wellness screenings to insurance assistance to food security, food RX, supplemental nutrition assistant program enrollments, behavioral health programs, oral health. So we do Skippy, where we travel to different schools and actually perform dental services to the schools. We have emergency fund administration, LEAP enrollments, Good Neighbor Fund. We provide transportation. We do full high fidelity wraparound care coordination. We also have a multicultural advocate committee team who works on legal services for immigrants in our community and does diversity, equity, and inclusion trainings to our local government. We have a volunteer coordination to support our palliative program, and then Communities That Care, which is a substance use coalition. So a wide variety of things.
I think your communities are really lucky to have such comprehensive services in a really rural area, so I want to ask you a couple of things kind of bundled together. One is, you had some mental health set up before the pandemic, and you were doing some really interesting things with telemental health in schools. And then COVID happened. So can you tell us a little bit about your telemental health before, and then how did everything change with COVID?
Yeah, so we actually started our online therapy program in 2017, just because some of the schools we serve in the vast regions didn't even have counselors. We also have in San Miguel County alone, 25% of our population is Spanish speaking. So we didn't have the clinicians available to speak and connect to the community members and provide services that they needed. So the program started before the pandemic, and it started just school-based. So we were going to the schools that didn't have school counselors, and we were connecting with administrators and teaching them our HIPAA compliant platform, how to launch it, how to connect, and sort of making sure they felt comfortable and champions of the telehealth program and platform. And then from there, we realized that it doesn't just need to stay within school and school staff. There's a lot of people we serve that don't have availability and access to clinicians and providers, whether that's transportation or whether that's financial barriers. We function on grants, so we're able to provide free therapy for our community members. So we took that success of school-based and applied for another grant called the Next 50 Initiative. The Next 50 Initiative was really successful in that we kind of gained more diversity in our in what clinicians were available to people who needed support. So again, we have the region's only bilingual, bicultural clinician available, which is huge. You want to be able to speak in your native tongue. You want to be able to speak to someone who understands your experience. And then we also recognize that, not everybody, like if a 10-year-old wants to talk to, a male clinician, we don't have a male clinician in the area. So we had to bring in these clinicians, and it was really supportive. When the pandemic hit, we sort of had to shift it, like our approach to school-based online therapy and then designated site facility therapy. So we would go to public health departments, to identified like champions in the community, like libraries, and have these set up computers, because a lot of our community members don't have strong internet, don't have computers. So then we sort of reevaluated what we could do, and wrote a little bit more grants for support, and gained more access to tech. So we were able to rent out technology, check out personal hotspots that people could utilize, and then actually do telehealth in the comfort of their own home. And we went from, I think it was at one point just 250 to now we're at close to like 600 people getting therapy, which doesn't sound like a lot, but I live in a really rural area, so that's actually a lot of people. But yeah, we kind of went with the flow. I worked a lot with my group, and I hearing what the speaker said before, it's all about collaboration, communication, and being open and receptive to learning new things. Like, okay, let's see how renting this tech is. We'll work with them. We'll go back to the pragmatic side and put together a step-by-step workflow so that the parents who are guiding now their students, instead of the school faculty guiding the students, feel supported in the process of launching the computer, getting the therapy set up, and then just making sure it was a smooth transition. But yeah, the grant pretty much wrote itself during the pandemic with how many people were able to use it and access it. And I was really lucky that our organization was kind of a pioneer in telehealth with our therapy. And then we were able to be ready to serve our community when the pandemic hit. Got really lucky in that.
Thank you. So, the pandemic has been really hard on all kinds of providers, and I know it's been really hard on mental health providers. How has telehealth, and I'm pretty sure I could say that telehealth is a mixed blessing for mental health providers, because sitting for 7 hours of therapy sessions back to back on Zoom could be pretty exhausting, I'm betting. But how has this affected the mental health providers in your community? And, be blunt. What's the good and the bad? Be honest, please.
Yeah, at first, that was something we feared. Like, are we going to step on the toes of the private practitioners in the community? But like I mentioned, we are in the suicide belt. We have a major mental health need in our area. And I am really close friends and best friends with Lindsay Wright, who's the behavioral health clinician at Telehealth Regional Medical Center. They aren't even able to support a lot of the community members we're able to. So a lot of them are immigrants that don't have legal status. They don't have the money to even see a private practitioner. And it also has just like given them a weight off their shoulder that they have to turn away clients at this time. Like, many private practitioners have a wait list of months, like, and even then they're not even sure if they're able to see you. So I at first feared kind of stepping into this territory of, oh my gosh, we're going to take away from these private practitioners, but then got a completely different reaction where, like, oh my gosh, thank you for supporting this large group of population that can't afford what my going rate is as a private practitioner, and then just to help me in general, because I can't maintain this client list. Because you're right, people were back to back to back with no breaks, working all day, facing compassion fatigue, secondary trauma. So this stepped in and kind of alleviated the stress and burden of our already established clinicians in the region. And we still don't have a psychiatrist in Telluride. It's all telehealth. So it's, yeah.
You're at the other end of the professional lifespan from me, Julia, and you could go anywhere. I mean, you could be in Denver. You know, I know you have ties back here in New Hampshire. You could be here. We tried to get her here in person, but it didn't work. So is telehealth going to make you more or less likely to stay or in rural mental health care, even, you know, depending even on where you might go? And what would you say to rural community leaders about telehealth and mental health?
That rural healthcare truly is at risk if we don't start implementing telehealth and really train our clinicians and support them in telehealth. I'm in love with the mountains. That's why I'm here. I'm sure that's why a lot of rural people are in love with their rural regions. Is I love living rural. But what I really want to say to community leaders is that mental health matters. And I spend a lot of time working with clinicians who say that we'll face the fallout of this pandemic on the mental health impact for the decade, at least. And it's going to encompass and affect all facets of our life. And mental health is health. And just reminding yourself to be a stigma stomper, to understand the importance that if you can't show up mentally, you can't show up, period, as a community member in any aspect. So we declared September as Suicide Prevention Month. Local governments can declare that, which stands and advocates for the fact that they understand that suicide is an issue. They acknowledge suicide as an issue, and they can implement all these different direct service community supports like mental health first aid, Safe Talk Suicide, National Alliance for Mental Illness. These are all organizations, grassroots efforts that are there to support rural communities that don't have the clinicians available. But just stay positive and continue to advocate to focus on the forward approach to healthcare, which I do think is telehealth in our rural region. That's my biggest message. Yeah.
So I could not have paid you guys to be more eloquent or profound. These are all the themes that you've hit on are all like close to my heart. You're lucky I didn't start to cry. I think, you know, Deb, we have some talking to do back up north about why did they do telehealth in schools for mental health? You know what?
Right.
Like, could you use that?
Yeah.
Right? Yeah.
Mm-hmm.
So I want to look to our tech people and see if we have questions. And I want to be a little bit careful. I'd like you guys to be able to talk to each other and ask questions, but I'm not sure mic-wise how that's going to go. But are there, I don't know if we lost Sharon, if we have any questions in the chat that people can, that the chat is there. And I'm trying to see if we have any questions from the chat or in the room. But do you have any questions for each other? Because I know I have Julia and Deb can talk to each other through this mic. So see if there's any questions. And are there questions from our colleagues in the room here? I can repeat them for you.
So just real quickly, a couple of you talked about community engagement, and you know you're busy with your other like real jobs, and so how do you and what helps you with that community engagement piece? And you know what you talked about engaging community to come in to do screening, but how do you find the time to engage communities, and what ways can we support health professionals and practitioners like you to engage the community better?
Okay, I'm going to repeat the question a little, summarize it, and then go to Deb because she's the easiest mic, and then to Lisa to the other mic. Is that going to work? Okay, so the question was that people talked about the importance of community engagement, but you all have like really busy day jobs. How are you going to add community engagement into your work, and what do you think are the strategies? Fair question. Okay, Deb.
Yeah, I mean, I'd say for me, it's kind of easy because I live in my community. So, my neighbors are part of the health center. When I go to the grocery store, my community is right there. So in terms of having the community engaged with the health center, I think we're just enmeshed, and the community, they're always asking, we just had a community barbecue, we tried to just do community outreach. We're really lucky like that I feel like the health center in the community are sort of one, and that the community they come in, when they need us, and if we need them, we put a call out and they're there. So yeah.
Okay, so if we could go to Lisa next, and then to Julia, and then to Robin, will that work with the mics?
Yes.
Maybe.
The main audio is on the mic is.
Okay.
So we passed the laptop. Yep, we passed the laptop.
All right. Well.
Okay. So I think my thought is to kind of be there every time, every conversation. I need to be positive about what I do. I need to feel good about why I'm there. I think you bring that to every conversation. You don't hide what you do. You don't kind of keep it off to the side. I'm very proud of being there. So I want to talk that way, every conversation, anytime I go somewhere, I'm going to tell you a little bit about that, the funny things, the difficult things, or whatever, but being open and being positive, I think, is the best way. I don't belong to a lot of groups in the Keene area because I don't live in Keene. I live a little bit away in Peterborough, which is half an hour away. But over time, you get to meet some people, you just, naturally. And I think it's being positive and being willing to talk and being willing to explain a little bit more. And I think, too, for myself professionally, is being willing to talk to people coming into the profession or wondering about it. I didn't know about nursing home work when I was in college. So how can I share that? Because becoming a nurse isn't just going to work in the ER, going to work on the hospital unit, going to work in orthopedics. There's a wide variety of nursing. And I think the more that people understand that, they can feel like they might have a place in it. I didn't know anything about teaching and education. I didn't go to school to be a nurse. I went to school to be a nurse. I didn't go in the teaching track, but I do more teaching every day than I ever would have thought of. So I think sharing that there's just so much to the role that each and every one of us do makes that community more engaged because they understand us more.
Great. Yeah, Sharon's given us a 6-minute warning, and we're right on schedule. I want you to know, unless you have any questions for me from anywhere else. So I'd like to go to Julia to answer that question now, and then get Robin up on the screen. I'm not sure if we can do that. So, Julia, what's your take on how you sound like you do a lot of community engagement, and it partly is your job, but you also have a lot of other things to do.
Oh, Robin's up.
Well, in nonprofits, you wear many different hats. It's kind of just the role in nonprofit organizations. But there are so many different grassroots organizations you can get involved with. In fact, being a community member and knowing how to respond in a mental health first aid crisis is the first step to guide them to an actual clinician to get even extra support. So researching mental health first aid in your region. It's offered for mental health first aid adults, youth, and teens. Teens is when you actually go to school and teach teens. It's similar to learning like a mnemonic device in CPR. So you learn how to respond to people with suicide ideation, people who are experiencing a panic attack. It empowers you to have tools in your tool belts so that you can support your community members, even if you're not a clinician. Because like we mentioned, in our rural areas, we don't have many clinicians. So you might be that first line of defense to recognize the early signs and symptoms of any mental illness, any anxiety, any bipolar type 1, type 2 showing up, substance use. National Alliance for Mental Illness is a family-to-family support group that's also recognized nationally. Google that chapter, see if it's in your region. It teaches you the skills. It's an 8-week evidence-based class that teaches you the skills, how to support your family members. I even say to your colleagues, to your friends, you learn the neuroscience behind depression, what medication is, how to be an advocate. If your loved one is dealing with the judicial system, it's an incredible organization that I recommend getting involved in. Safe Talk Suicide. It's also a 4-hour free course where you learn all the crisis resources in your area, what to say to de-escalate someone who has suicidal ideation. And again, this just takes the pressure of rural areas and rural people who may not have clinicians at hand, and empowers community members to know what to say and how to say it. So you're being helpful to support friends and family. And then bottom line, just be kind. Like everyone in this room, we've been going through a lot. So, I do vaccine outreaches, and I know that that's somehow become political. But just know it's all from the intention of helping one another in health and supporting one another. So even though we may have different opinions, thoughts, and feelings, just be kind to one another.
Sorry, I had to wait to be unmuted. So because Maplewood is a county-run and owned facility, I would have to say that the way I communicate mostly with the community is they're asking me, hey, how's everything up there at Maplewood going? I think a lot of it depends on the community that you live in. Like Lisa, I live in Keene, but I work in Westmoreland, which is about a half hour away, but they're both in Cheshire County. So everybody know I've been here for 25 years. So everybody knows me and that I work at Maplewood, and my job isn't over when I leave the campus. My job continues on as I'm going about my own activities of daily living, and just sharing with everybody what's going on and how they can best help. We use Facebook as a platform. We have a Maplewood Facebook page. We send out our help wanteds out on that. We send out if we're in need of something. We did tie-dye t-shirts for the residents. So we sent out a message on Facebook, hey, anybody who wants to donate a white t-shirt, we're going to tie-dye t-shirts. So social media can be a good platform as long as it's controlled and used in a limited and responsible way. But I think the community is more interested in what's going on. So all you have to do is get the message out there.
I think you've heard a lot about the potential for telehealth. You've heard a lot about how Project ECHO can help people stay connected professionally and stay learning. There is a subtext though, and here's my speech, is that none of this is going to work if we don't have better broadband, right? I think we've all been challenged with that. You can be even in the center of a pretty big town like Keene and have a college down the road and still have some tricky broadband. We also, in most rural areas, may not have really good cell phone service. So unless we get that lit, we're going to make the telehealth work. We're going to make it work better. But unless we make some significant progress on that, it's going to be a challenge. And I also want to thank our panelists and our track leader, but this incredible tech crew that has had to troubleshoot and tap dance us all the way for the last 2 hours. You have my applause.